Partnership-defined quality is a methodology to improve quality and accessibility of services by engaging community members in defining, implementing, and monitoring the quality of service delivery. Through the PDQ process, service providers and community members are empowered to develop local solutions together. Why should communities be engaged? For a variety of reasons, many efforts to improve quality may not consider community concerns and perspectives about quality of care. As a result, improvement efforts can fail to meet the needs of community members. Since PDQ was developed by Save the Children in 2003, it has been implemented in over 15 countries, linking health quality improvement efforts with community mobilization. PDQ can be applied to solve a variety of community problems and improve services, including education, food security, HIV and AIDS, and healthcare. It has most often been used to increase access to health services by marginalized groups. This video illustrates how Medical Teams International is using PDQ to improve quality of health service delivery in Grand Cape Mount County, Liberia. The process includes 4 phases. Phase 1 involves building support among stakeholders to engage in the PDQ process. Phase 2 is all about exploring quality, as information is gathered from vulnerable community groups and service providers to learn what quality health services mean to them. In Phase 3, called Bridging the Gap, community groups and service providers come together to examine and agree upon a set of problems. Phase 4 continues indefinitely as a community-level quality improvement team works in partnership to address the identified problems. A successful PDQ process requires thorough planning and design in advance of beginning the 4 phases of implementation. It starts with determining whether PDQ makes sense to use in a given community and by assigning roles among NGO staff based on individual skills and aptitudes.
Okay, now I think we have all of our skills and the staff that will work with these skills to have the PDQ process going on. So we can move now to the next step.
Critical planning components include identifying the needed skills and resources amongst your staff, defining your NGO's goals for PDQ, identifying the level of service for implementing PDQ, defining the type of services and mapping the community needs and resources, planning for participation and representation, identifying other quality improvement initiatives in your community or region, and other partners who are implementing them. Once these planning and design steps have been taken and you have the information you need, the PDQ process begins with Phase 1, building support.
My name is Richard and my friend here is Senesi. We come from MTI and we come to tell you about something that will bring us together so we can work as one group. All right? So MTI show us some way. They call a process PDQ. PDQ means partnership defined quality. Partnership is working together, right? Define is to make the meaning of, tell you something. Then the quality is the way you want things to be, the way you look at your standard, your own standard.
In a small village within Grand Cape Mount County, facilitators from MTI begin the PDQ process by conducting meetings with different community stakeholders. Sometimes this can be done as one joint stakeholders meeting. There are 2 reasons for this initial meeting. The first is to gain consensus on the existence of the problem.
Fine, thank you. That's another problem. You see, I see we get plenty of work in the community here.
And the second is to gain the support from community leaders to use PDQ to help address the problem. In the case of Liberia, One of the main problems was that pregnant women were not delivering in the health facilities. The stakeholders agreed that this was a problem they could not address on their own. Once MTI explained the PDQ process, the stakeholders agreed to give their support to implement it in their community. It is also critical to the success of the building support phase that the community members identify and agree on who are the most vulnerable groups in their community who are not fully utilizing services.
Who you think in a place here that need the clinic most?
Your question says that amongst the people of the catchment towns, who are the groups and that most needed the clinics, right? Me, I've seen the children.
Secondly, pregnant women.
If they're pregnant will be nice. Pregnant will be.
Nyanga.
Women, eh?
Yeah.
Hearing the voices of these vulnerable groups will be crucial as the PDQ process moves forward.
Stakeholder meetings is like what we call community entry. You must get into the community with the consensus of the community leaders.
You want to involve the community, and that methodology is like you are setting an idea.
So it is always important to engage the stakeholders and get their consensus before getting into the process.
Once support for the PDQ process has been established and the process has been thoroughly explained, focus group discussions are conducted to explore how quality services are understood by each of the parties involved. Separate meetings should be held for each of the vulnerable groups identified in the building support phase. In Liberia, vulnerable groups were identified as pregnant women, women with small children, and the elderly. Focus group discussions were also held with clinical and non-clinical staff, community health workers, community health volunteers, and trained traditional midwives. Quality services are not one size fits all. Perceptions and expectations of quality are shaped by people's own understanding and personal experience. One way to guide participants in their understanding of what constitutes quality is to use an analogy that is familiar in daily life. For example, how one chooses quality food in an open marketplace.
And we got to the market there. When we get to the market, we see plenty of people selling cassava. That waiting will make you to buy from the person. All the people selling you, but you look at one person and say, the person buy me, I will buy the cassava from the person.
They get some cassava, like get plenty of vin inside.
Yes.
So if my apple see that no vin inside again, don't good, like I buy.
If you're selling the cassava, the first thing I will look at the seller.
The seller.
If the seller is clean, because if the seller clean, that means we'll be able to take that cassava will be clean because it be able to take care of the cassava.
Because PDQ is a rights-based approach, sometimes role-playing in a brief socio-drama can also be used in the exploring quality phase. In Liberia, participants demonstrate how they feel when receiving services that they have the right to receive at the health center.
I paid $200.
To who?
To the doctor.
Oh, doctor?
Yeah. My son.
Don't tell her. Don't tell her. That thing are free. You know that the people will do all kind of things to all in the place. We can't get one in the government or we can't pay all. So when you go say to your home, don't tell anybody. The medicine here for you is free.
Focus group discussions are a powerful way of hearing the voice of people who may not be using the health facility. As they listen to each other, they become more aware of their common concerns.
I say I will not be able to go take medicine there. But let me try, I go Sinji. Sinji probably can get medicine there good. So I go in Sinji to go take my medicine there. And when I enter Sinji clean there, they can give me good medicine, they can check me good. So I see to there that Sinji will be taking my medicine here. I will not be taking medicine in Kanga clean there again. Because they can't give us good medicine in Kanga clean there.
We are ready and we are willing and we are very free to do it. Nothing, nobody forcing us. We are doing it willingly. We want our community to improve, especially so on the medical side. We want the community to improve.
When facilitated properly, these focus group discussions allow for a free, open exchange of ideas that will begin to define obstacles that can diminish quality, as well as identify strengths in the delivery of existing services.
In our setting, Africa and Liberia, women are not heard. They are marginalized based on religion and tradition. And so, in this PDQ process, we bring them in and they express all of their dissatisfactions.
The thing that happened in the meeting here is satisfy me. Because the point that came to us, they talked to us good.
People here miss no in the time here to build the hospital, to build our clinic, they miss no here. Capital here. But at least you can bring your own help to help out to build the clinic. So all I'm going to bring here today to all, it may also satisfy because that good thing you bring to all, good plan you bring to all here.
They know their own problems, and they are going to say their own problem to us, and they are going to be part of the solution process, and which, if they are part, I believe that will be sustainable.
Throughout these discussions, staff from the NGO conducting the PDQ process must accurately record the issues and concerns raised. These important notes will form the agenda for the next phase of the process, bridging the gap. To prepare for the day-long Bridging the Gap session, NGO staff meet to summarize and analyze what was learned through the focus group discussions. They make lists of complaints and concerns raised from each community or provider group. Each list is reviewed to remove duplicate responses. Then the community lists are grouped into one community list, and the provider lists are grouped into one provider list. It may also be helpful to group responses into categories such as place and environment issues, medical supplies and equipment, technical competence of providers, client-provider relations, and others. Once the NGO team has synthesized and grouped the complaints and concerns from the community and provider groups, they then write or print out individual sheets for each complaint to present to participants during the Bridging the Gap session.
I want to say thank you for leaving your work this morning to come, because we know that it's for ourselves, right? We've been here 2 times. This is the 3rd time we're here now, right? Today, we're bridging the gap. Bridging the gap means the problem that we see from this side, from the community, the problem that we see from the clinic, we bring it all together. And then we started thinking on how we can solve the problem.
The Bridging the Gap session is a critical component of the PDQ methodology. The purpose of this extensive meeting is to share with the community members who participated in the various Exploring Quality focus group meetings what was learned from all the discussions. Each group has the opportunity to express their own views on quality. The groups must now bridge the language, cultural, user, and provider gaps to engage in sincere dialogue about the priority problems they have identified in their community. This phase is the launching point for the ongoing Quality Improvement Initiative.
Hello? Thank you. 1 clap. Thank you.
After a warm-up exercise, the lists of complaints and concerns that were prepared by the NGO implementation team are considered, discussed, and arranged by the participants. Issues raised by community members, the vulnerable groups, are placed on one side of a wall, and those identified by service providers are placed on the other side with empty space available between the sides. Participants are asked to read the complaints and concerns on both the community side and the provider side. Participants then select problems from each side that look similar. If everyone agrees that the 2 complaints are similar, the facilitator guides the group to state the actual problem.
Patients talk to us aggressively. We all agree that they are the same problem, right?
Yes. But the doctor talked to me good. I will talk to her good. I paid her. But I went to her, she didn't talk to me good.
What is the cause?
There's a problem with communication.
Yeah, so is that we don't know how to talk to each other, right?
And then adds it to the list in the middle of the wall. There are many ways to do this, and communities can get very creative.
This for the clinic, no maternity waiting room for pregnant women. Then for the community, no big belly horse for our pregnant women to remit or deliver when they are nearing delivery. It's the same problem.
There can be some tension or defensiveness among participants as problems are discussed. So it's critical for these sessions to be led by a neutral facilitator who can gently remind people they are all in this for the common goal of improving their community. Once a number of problems have been agreed upon, the group takes a break. This reduces communication barriers and creates a relaxed and positive atmosphere for working together. In the next step of the Bridging the Gap session, participants identify common problems and align related sub-problems as they arise to better understand patterns and explore associations between issues.
So you see the problems are written now, they are in here writing. If you see anything linked to any problem over there or complaint that linked to this problem, you come and just put it underneath it so that we can know this is the me problem, but what? Other things that look like it.
Please note that this is often a messy process. This is okay. If there are significant problems addressed on the community side that were not mentioned by providers or vice versa, participants need to discuss if it is actually worth addressing.
The big one we got here, the clinic is in bad shape.
The list of identified problems in the middle of the wall represent the joint decisions made by all present. Once they have a good number of problems identified, they're ready to move toward the next step of solving these problems. Most communities identify 6 to 8 problems during the Bridging the Gap phase. At this point, an NGO facilitator describes the concept of a quality improvement team. This team is selected by the participants with special attention paid to gender equity, inclusion of members from each vulnerable group, as well as community members and service providers, for a total of around 15 people. The facilitator asks participants to select QIT members based on 3 key criteria. The person should be well respected, have interest in promoting health of the marginalized, and have time to come to monthly meetings. The facilitator also describes key responsibilities of QIT members: attend monthly meetings, be cooperative, do volunteer work to complete the action plan, conduct community mobilization and health education, and promote the community health needs to political leaders. This Quality Improvement Team, or QIT, will work together on an ongoing basis to address the issues defined through the Bridging the Gap session.
I, of the QIT of Kanga Clinic, do hereby swear that I will work in the interest of my people, and see that quality is brought to our community clinic.
The new QIT members then make a formal pledge to support their communities and take on their first task to determine when and where the group will hold their first meeting.
Kanga Town Hall. In Kanga Town Hall. A PDQ process is not a very easy thing. It's difficult, but it's beneficial. Facilitators, people that want to be part of this thing, should have patience. They must know that they are working for the general good of every community they go into.
Some things that the community was not able to do, now today, the QRT and the way you people explain it to all well, now the community will be able to help themselves to carry the community ahead.
Because we need our clinics to be neat, to be built. For now, we're just asking God and ourselves to work on it.
The 4th phase of the PDQ process is working in partnership. This phase begins with the first meeting of the Quality Improvement Team. To get things started, a culturally appropriate team-building game is led by the facilitator.
the rule, y'all listen good, or the rule of the game is do not allow your foot to touch the ground. We want everything on the paper. All right? It's good, right? Everybody's on, right? Yeah. Okay, good. Come up. Okay. Take your own paper and fold it equal half. We want the same 4 persons to go back on our paper and let all your feet be on the paper the same way.
This exercise creates an atmosphere of fun for the meeting and can help remove social barriers between members of a diverse group. As the task of fitting onto a shrinking sheet of paper grows more difficult, the facilitator suggests an innovative approach that works within the guidelines of the game.
Now, sit around the paper on the ground and try to put your feet on that paper and see whether everybody will have their feet there without touching the ground. So we're telling you that it is possible if you just think of all the possibilities, all the different ways. So thank you. Is there anybody who can explain to us why this exercise was done?
If you're together, nobody will see between you. If you're together, you will do things that will be developed for your own self tomorrow.
With the ice broken, the QIT then begins the process of organizing themselves. Ground rules are established. Team leaders are selected, including a chairperson and a secretary who will be responsible for recording minutes of the meetings. Now the fundamental work of the QIT begins.
Remember when we had a Bridging the Gap meeting, we identified some problems in our community, correct? We can remember them. Anybody can remember one of them?
Staff approach was not good to the community people.
The group discusses the challenges that were agreed upon at the Bridging the Gap session, the relative priority of each issue, and selects one on which to focus first.
So you see, you put your problems in order now, right? Yeah. And this is how we're going to solve them, correct? Yes. We all agree. Fine.
As the group learns to work together, the NGO facilitator provides tools for problem analysis and action planning, starting with a diagram to guide discussion about the root causes of the problem.
Lack of communication between the community people and the clinic staff, good communication. The QIT can solve that. The QIT can bring them together. So we say they start by approach. The main reason is we lack good communication between us, right? So can we take this as the main cause of this? Lack communication, this is something that we can work on.
The QIT then creates an action plan to guide their work and a tracking table to keep tabs on progress as the project moves forward.
Now this thing we put up here is to tell us, we say we'll do that, but how do we know that it is done already? So we call that tracking table, all right?
While demonstrating these tools for discussion and problem solving, the implementing NGO should emphasize that the QIT is engaging in a continuous process of problem identification, proposal of problem solutions, implementation, and assessment. As QITs become more adept at problem solving together and see their progress, they understand the importance of their ongoing role as agents of change. After guiding the community through the 4 phases, the implementing NGO can contribute to the long-term success of the QIT through monitoring and evaluation. Monitoring tools can include careful observation of a QIT meeting in progress while completing a quality improvement verification checklist and then sharing feedback based on the observation with QIT members.
We got a paper here, we'll be looking at you when you're having a meeting, so must see if whether the meeting going the right way. Let me just read the questions fast and I will be answering it for you. A QIT meeting conducted as agreed upon, usually monthly basis? I said yes. The reason why I said yes, because the meaning they read our from last month meeting, September, are at least 70% of members of the QIT in attendance at this meeting. But I say yeah because the meeting are almost 100% here. They say, are you sure, as the reviewer, satisfied with progress of the QIT? And I must say no. So I say yes. Okay, reason why I'm satisfied? The level the work has reached.
A team effectiveness questionnaire is another tool that assesses the functioning of the QIT, but from an individual member's perspective. This gauges whether they feel that their contribution is valued.
Your own contribution to the QIT, you think is...
Good afternoon.
Yeah,
Okay, can I ask you some questions pertaining to your health?
One way of monitoring change in client satisfaction at the health clinic is to conduct confidential exit interviews with community members after they leave the health facility. These results are then fed back to the QIT each month. As a quality improvement team continues to progress, NGO staff should regularly check in on ongoing activities and review documentation of service records. In Liberia, this step includes analyzing reported clinic data on facility-assisted deliveries.
People was like complaining the distance is far. I would not be able to come to the facility to give birth. I'd rather give birth in my town. Sometimes the people that gave birth, they started to bleed. People having sepsis, all this kind of thing. We lost life in it. Yeah, the QIT came together using the CHDC, the GCAV, and the TTMs. Because they are part of the QIT. So we call them, tell them the importance of having this staff quarter closer to the clinic. It's more easy to deliver.
When the QRT was not formed, we found it difficult for patients to come at the clinic because there was no relationship between the community and the clinic. But we will have the bridge in the gap meeting, and then we funnel the QRT. We, the staff in the clinic, took the blame. And I took the blame, and I called the member of the community where everybody, town chiefs, elder, were all there, present, and then I lied down in the midst of them, and I told them I took the blame. We forget about the past, and we work together.
Anything that we want to do, the QRT have to come together and discuss.
We've been going from village to village to talk to people that we can able to come together and do this work for ourselves.
Engaging community stakeholders through the PDQ methodology has led to ongoing improvements in quality of services and tangible results in underserved communities all over the world. This rights-based approach promotes equity by engaging vulnerable groups who are not usually included in decision-making. The process transforms communities by empowering these groups to take charge of their own health and well-being.